Now let me discuss the important MCQs in the pharmacology of the heart failure. The drug of choice in acute congestive heart failure with fluid overload will be diuretics. If the patient is having fluid overload, then the drug of choice will be diuretics. If the patient is not having the fluid overload, then the drug of choice will be AC inhibitors. Next, the drugs which will decrease the mortality in patients with the congestive heart failure. The drugs include the AC inhibitors, beta blockers, angiotensin receptor blockers, and as well as the aldosterone antagonist. The other important MCQs will be asked on the cardiac glycosides. Remember, among all the cardiac glycosides, we have digoxin, digitoxin, oubain, but among all these, digoxin is the most commonly used cardiac glycoside which will increase the cardiac output in the individual. And if you see the mechanism of action, the main mechanism of action of the digoxin is digoxin will inhibit the sodium potassium ATPase within the cell, or the sodium potassium ATPase which is present in the cell membrane of a cell. Now by inhibiting this sodium potassium ATPase, what will happen? There will be activation of the sodium calcium exchanger. As and when there is an activation of the sodium calcium exchanger, the calcium level within the cell increases, and that will increase the contractility of the cell. Now the other important MCQ which will be asked is the differences between your digoxin and as well as the digitoxin. If you take the half-life of digoxin, it is 24 to 36 hours, and if you take the half-life of digitoxin, the half-life is 165 hours. The other important MCQ is, if you take the digoxin metabolism, digoxin, it is metabolized in the kidney, so it is contraindicated in renal failure. Digitoxin, it is metabolized within the liver, so it is contraindicated in liver failure. Now the other important MCQs that will be asked is the contraindications of digoxin. Digoxin, it is contraindicated in partial heart block. Why? Because it will increase the delay in the AV nodal conduction. Because it will increase the delay in AV node conduction, that is the reason why they are contraindicated in partial heart block. And remember, digoxin is also contraindicated in hypertrophic cardiomyopathy, WPW syndrome, myxedema, and renal failure. These are all the conditions where the digoxin is contraindicated. The other important MCQ about the digoxin is, you need to know about the digoxin toxicity. There are certain factors or there are certain conditions which will precipitate the digoxin toxicity. What are those factors is thiazides, quinidine, hypercalcemia, hypomagnesemia. Remember, these are the factors or drugs or the conditions which will precipitate the digoxin toxicity. Now, as and when there is digoxin toxicity, what should be the line of treatment? If for suppose, if there is any drug causing digoxin toxicity, discontinue that particular drug. Next, the important manifestation of the digoxin toxicity is the development of ventricular arrhythmias. So, the drug of choice for digitalis induced ventricular arrhythmia is lignocaine. That is an important MCQ. Whereas the drug of choice for digitalis induced atrial arrhythmia, it will be atropine. So remember, for ventricular arrhythmia caused by digitalis, lignocaine is a drug of choice. For atrial arrhythmia caused by digoxin, atropine is a drug of choice. Whereas in case of a very severe toxicity caused by digitalis, the drug of choice is a digibind. It is a FAB antibody. And remember, whenever you are giving digoxin, in case of digoxin toxicity, digoxin, it gets concentrated in the heart. So that is the reason why there is no role of hemodialysis in patients with the digoxin toxicity. The other important MCQs is about the natriuretic peptide analogues. Examples include nesiritide, carvedilol, next is ularitide. The mechanism of action of these drugs, these are a recombinant human B-type natriuretic peptide used in acute heart failure. This recombinant form is a naturally occurring hormone which is secreted by the ventricles, and they will increase the cyclic GMP in the vascular smooth muscles, and therefore they will reduce the venous and as well as the arteriolar tone. And this natriuretic peptides also cause natriuresis. That means they will reduce the fluid overload in a patient with the congestive heart failure. What are the uses of these natriuretic peptides? They are used in acutely decompensated heart failure associated with dyspnea at rest. And remember, the side effect of this particular natriuretic peptides is hypotension is the most common side effect with this particular natriuretic peptides. And if you take the carvedilol, it is a atrial natriuretic peptide analog. So these are some of the important MCQs which will be asked in the pharmacology of the congestive heart failure. Now let us discuss some of the important MCQs in congestive heart failure pharmacology. If you take the first question, the most important channel of elimination of digoxin is A. glomerular filtration, B. tubular secretion, C. hepatic metabolism, D. excretion in the bile. So as we have discussed that the digoxin, it is metabolized in the kidney. Now what are the two options which will make you confused in the exam is about the glomerular filtration and tubular secretion. We can easily rule out the hepatic metabolism and excretion in the bile. Why? Because it is your digitoxin which is metabolized in the liver. So digitoxin will be excreted in the bile or it is metabolized in the liver. Now our question is on the digoxin. So digoxin, it is primarily eliminated unchanged by glomerular filtration. Remember, it is not eliminated by tubular secretion, it is eliminated unchanged by glomerular filtration. Now let me discuss the other MCQ, that is, all of the following are seen in digitalis toxicity except number 1, ventricular bigeminy, number 2, paroxysmal atrial tachycardia with fast ventricular rate, number 3, regularization of the atrial fibrillation, number 4th option is bidirectional ventricular tachycardia. Now if you see this question, going back to the discussion on the digitalis toxicity, I said you that the earliest manifestation in digitalis toxicity will be vomiting and as well as the nausea. In case of the severe toxicity due to digitalis, arrhythmias are very common. And what did we discuss? The most common type of arrhythmias what we see in the digitalis toxicity is the ventricular bigeminy. But it will not cause the increase in ventricular rate. What did we discuss? These are the drugs which are used in the atrial fibrillation with fast ventricular rate. When we give this digoxin, digoxin will increase the refractory period in the AV node. So when digoxin is increasing the refractory period in the AV node, what it will do to the ventricular rate? It will reduce the ventricular rate. So the one which the digoxin will not cause, that is the question is except, which is the false statement. So the one digoxin will not cause is paroxysmal atrial tachycardia with fast ventricular rate. It will not increase the ventricular rate. Definitely if you see the regularization of the atrial fibrillation, remember this particular digoxin, it is used as a maintenance therapy for the treatment of the patients with the atrial fibrillation, and it will also cause a biventricular tachycardia. Next MCQ, digitalis toxicity is increased by all except. So what did we discuss? If you see the multiple choice options, A, renal impairment, B, hyperkalemia, C, hypercalcemia, D, hypomagnesemia. What did we discuss is, whenever the potassium level increases, potassium, it comes and binds with the receptor where the digoxin is binding. So in patients with hyperkalemia, digoxin toxicity is not increased. In fact, hypokalemia will increase the digoxin toxicity. Whereas if you take the other options, renal impairment, definitely the digoxin toxicity increases. Why? Because the digoxin has to be metabolized and excreted through the glomerular filtration. So if the individual has renal impairment, digoxin toxicity increases. And if you take the other electrolyte disturbance, hypercalcemia and hypomagnesemia will increase the digoxin toxicity. But remember, it is not your hyperkalemia which will increase the digoxin toxicity, it is your hypokalemia which will increase the digoxin toxicity. Now, the other MCQ is, which of the following is a monovalent cation that can reverse a digitalis induced arrhythmia? Options are digibine antibodies, second option lignocaine, third option magnesium, fourth option potassium. Remember, digibine antibodies, they are given as a part of treatment for very severe digoxin toxicity. But for reversing the digitalis induced ventricular arrhythmia, lignocaine is the monovalent cation which will reverse the digitalis induced arrhythmia. And if you take the magnesium and as well as the potassium, they are not used for reversing the digitalis induced arrhythmia. Next MCQ, the following drugs have significant drug interaction with digoxin except. Options are cholestyramine, thiazide diuretics, quinidine and amlodipine. Now, we have also discussed the drugs which will increase the digoxin toxicity, and among all these, remember, it is your amlodipine which will not cause the drug interaction with the digoxin. For example, you take this cholestyramine. What the cholestyramine will do is, cholestyramine will inhibit the intestinal absorption of the digoxin. So, when cholestyramine is inhibiting the intestinal absorption of digoxin, what is it doing to the digoxin levels? It is reducing the digoxin levels. That means it is having a significant drug interaction with the digoxin. If you take the thiazide diuretics will increase the digoxin toxicity. How? These thiazide diuretics, they will cause hypokalemia. When thiazide diuretics cause hypokalemia, just now what did we discuss? Hypokalemia is one of the precipitating factor for digoxin toxicity. So, thiazide diuretics has a significant drug interaction with the digoxin. Next, if you take quinidine, remember we have two drugs, quinidine and as well as verapamil. These two drugs will reduce the excretion of the digoxin, and thus they may precipitate the toxicity which is being caused by the digoxin. Next MCQ, if you see, digitalis is used in the treatment of acute congestive heart failure. It can also be used as a long-term maintenance therapy if congestive heart failure is associated with. Remember, if you take the drugs which are used in acute congestive heart failure, I have discussed that we mainly give the diuretics and as well as the inotropic agents. If you take the diuretics, they are given only in the acute phase and then they are stopped. If you take the inotropic agents, for example dobutamine, it is given only in the acute phase and then it is stopped. And you take inodilators, it is given in acute phase and then stopped. The only inotropic agent which can be given or which is given in acute phase and as well as maintenance therapy, it is your digoxin. Now, what is the added advantage why we give this particular digoxin as a long-term maintenance therapy is because it is used in the treatment of atrial fibrillation. So, remember, digitalis is used to maintain the ventricular rate in patients with the atrial fibrillation. So, that is the reason why digoxin, it is given as a maintenance therapy in patients with congestive heart failure. Now, if you see the next MCQ, a patient of atrial fibrillation is on digoxin therapy. Which of the following responses do you expect in this patient? Number 1, restoration of the normal sinus rhythm. Number 2, conversion of atrial fibrillation to atrial flutter. Number 3, increase in atrial fibrillation frequency but decrease in the ventricular rate. Number 4, decrease in atrial fibrillation frequency but increase in ventricular rate. Now, if you see this particular question, whenever we are giving this particular digoxin therapy in atrial fibrillation, what it will do is, it will increase the, what is the response what we expect in a patient with digoxin therapy in atrial fibrillation is, it increases in atrial fibrillation frequency but decreases the ventricular rate. The only reason why we are giving digoxin is, it will reduce the ventricular rate in patients with the atrial fibrillation. How? By increasing the refractory period within the AV node. So, digitalis controls the ventricular rate in atrial fibrillation patients. The frequency of atrial fibrillation may actually increase, but it will reduce the ventricular rate. And we have another drug which has been approved, that is ibutylite, is approved for conversion of the atrial fibrillation to sinus rhythm. Now we have another important MCQ, the contraindications of digoxin. Digoxin is contraindicated in supraventricular tachycardia, atrial fibrillation, congestive heart failure and hypertrophic obstructive cardiomyopathy. If you go back and refer what are the contraindications of digoxin, remember digoxin is contraindicated in patients with hypertrophic obstructive cardiomyopathy. And what is the drug of choice for hypertrophic obstructive cardiomyopathy? It is your non-selective beta blockers. Now you go back and revise the contraindications of digoxin. Next MCQ is the time taken for digitalization is option A 36 hours, option B 12 hours, option C 5 days and option D 10 days. Remember, the time taken for digitalization is 5 days. Next MCQ, which among the following is the best inotropic drug for the use in right-sided heart failure? The question is very important. In right-sided heart failure, remember we have the options like dobutamine, digoxin, dopamine and as well as milrinone. All these are inotropic agents, but the inotropic agent which is used in right-sided heart failure is your milrinone. Remember, inotropic agents, they are not used for the treatment of right-sided heart failure, whereas the major treatment is diuretics and as well as the vasodilators. But if you take the milrinone, it is being a phosphodiesterase inhibitor. It acts as inodilator. So this is the only inotropic drug that should be used in right-sided heart failure due to its ability to produce vasodilatation. So remember, milrinone is the only drug which can be used in patients with the right-sided heart failure, and it is also indicated in right heart failure with pulmonary hypertension. Next MCQ, if you see, which of the following drug is beneficial in refractory congestive heart failure by increasing the cardiac contractility and decreasing the preload and afterload? If you see the options here, amiloride, amiodarone, amrinone and carvedilol. The answer here is C, that is amrinone. Why? Because it is a phosphodiesterase inhibitor. So it acts as the inodilator. That is, it is having a positive inotropic effect. That is, it will increase the cardiac contractility as well as it also has the vasodilatory action. By having this vasodilatory action, it will decrease the preload and it will also decrease the afterload in a patient with the congestive heart failure. So remember, among all these drugs, the amrinone is the drug which is used in patients with the a refractory congestive heart failure. Next question, if you see, brain natriuretic peptide, it is degraded by neutral endopeptidase, elastase, omapatrilat and angiotensin converting enzyme. Remember, you should not get confused with the third option, that is omapatrilat. Omapatrilat is a neutral endopeptidase inhibitor, but if you take the BNP, it is degraded by your neutral endopeptidase. For inhibition of this neutral endopeptidase, we give omapatrilat and we will also give sampatrilat. These are the two drugs which will act as inhibitors of the neutral endopeptidase and thereby increasing the levels of brain natriuretic peptide, which is used in patients with the chronic congestive heart failure. And if you see the next question, all of the following statements about nesiritide are true except. So what is this question about? This question is about like which is the false statement about the nesiritide. Option A, it is a BNP analog. Second option, it can be used in decompensated congestive heart failure. Number 3, it can be administered orally. Number 4, it causes the loss of sodium in the urine. So he is asking about which is the false statement. Remember, as already we have discussed, you take this nesiritide, it is a recombinant brain natriuretic peptide. So first option is a correct option. And if you take these drugs can be given in acutely decompensated heart failure, we can give nesiritide. But the drug which is not given in decompensated heart failure is beta blockers. Beta blockers should not be given in patients with the decompensated heart failure. And remember the route of administration. Nesiritide, it is not given orally. Nesiritide, it has to be administered by the intravenous route. Why? Because it is being a peptide, it is metabolized by peptidases in the GIT. So that is the reason why if you give orally the nesiritide, it is being digested by the peptidases in the GIT. So these drugs should not be given orally, these are given intravenously. And if you see the action of this particular nesiritide, it will produce vasodilation. Nesiritide also will cause natriuresis. So if you take the fourth option, it causes the loss of the sodium in the urine is a correct option. Now you see the next MCQ. The arteriolar dilators used in the treatment of the congestive heart failure include option A hydralazine, option B nifedipine, option C prazosin, option D enalapril, option E nitrates. Now among all these drugs, what is the use of using arteriolar dilators? If you use arteriolar dilators in patients with congestive heart failure, they will reduce the afterload on the heart. So the drugs which are used are hydralazine is the correct answer. Nifedipine, it's a calcium channel blocker, can be used in the treatment of congestive heart failure, but remember the calcium channel blockers which are not used is verapamil and diltiazem, should not be used in patients with the congestive heart failure. And if you take option C, that is prazosin, prazosin is nothing but your alpha blocker. Alpha blockers will reduce the afterload on the heart, so we can also give the prazosin. And you take the option D, that is enalapril. Enalapril is an AC inhibitor. Remember, these AC inhibitors, they will cause arteriolar vasodilation. When AC inhibitors, when they cause arteriolar vasodilatation, they can be used in reducing the afterload in patients with the congestive heart failure. But if you take the last option, that is nitrates, remember nitrates are the venodilators. Any drug whichever is causing venodilatation will reduce the preload but not the afterload. Coming to the next MCQ, drugs associated with a clinically useful or the physiologically important positive inotropic effects include all of the following except option A amrinone, option B enalapril, option C digoxin, option D dobutamine. If you take among all these options, the question which is being asked is, it should be useful or it should be physiologically important positive inotropic effect, but the question is except. That means which among the following drugs is not an inotropic agent. You take amrinone. Amrinone is an inodilator. That means it is causing inotropicity, it will increase the cardiac contractility. You take option C, that is digoxin. Digoxin is the drug which will increase the cardiac contractility. So it is also a positive inotropic agent. And you take dobutamine. Dobutamine is also a positive inotropic agent. But if you take the option B, that is enalapril. Enalapril is not having inotropic action. Enalapril, it is a AC inhibitor. So it will not increase the inotropic effect on the heart. And enalapril, remember, it will reduce both the preload and it will also reduce the afterload on the heart. And if you take the next MCQ, drugs that have been found to be useful in compensated heart failure include all of the following except option A sodium potassium ATPase inhibitors, option B alpha blockers, option C the beta receptor agonists, option D the beta receptor antagonists. Remember, the sodium potassium ATPase inhibitors, they include your digoxin. Digoxin we give in patients with the compensated heart failure. You take the alpha blockers. Alpha blockers include mainly your prazosin. Prazosin or alpha blockers we give in patients with compensated heart failure mainly to reduce the afterload on the heart, because alpha blockers are your arteriolar vasodilators. And if you take the option D, that is beta receptor antagonist. Beta receptor antagonist, which beta receptor antagonist we have to use? We have to use a selective beta 1 receptor antagonist. They will reduce the activity of renin angiotensin aldosterone system, and those beta 1 receptor antagonists include carvedilol, metoprolol and as well as bisoprolol. The drugs which are not being used is a beta receptor agonist. The beta receptor agonists, they include salbutamol, terbutaline, salmeterol, formoterol. Where are they used? They are used in patients with asthma, not in patients with the compensated heart failure. If you take the next MCQ, angiotensin converting enzyme inhibitors are useful in congestive heart failure as first option, first choice drugs unless contraindicated, B an alternative to diuretics, C a substitute for digitalis, D adjuncts only in resistant cases. Let me tell you an important point about ACE inhibitors. ACE inhibitors are the drug of choice in patients with the congestive heart failure. Remember, these are the drugs which are used unless until contraindicated. We have seen the contraindications that include pregnancy, these are contraindicated. Bilateral renal artery stenosis, these are contraindicated. In chronic renal failure, these are contraindicated. Until unless the patient have these contraindications, the ACE inhibitors, they can be used as a first choice drugs. They are never an alternative to diuretics. Along with diuretics, we can give this ACE inhibitors. Next MCQ, if you see, all of the following are the actions of the beta-adrenergic blockers in CHF except option A, decreases the mortality associated with the congestive heart failure. Option B, antagonism of vasoconstriction due to sympathetic overactivity. Option C, prevention of pathological remodeling of ventricular myocardium. Option D, prevention of a dangerous cardiac arrhythmias. If you take the options here, remember there are the following list of drugs which will decrease the mortality in a patient with the congestive heart failure. Those drugs include ACE inhibitors, angiotensin receptor blockers, aldosterone antagonists and beta blockers. They will decrease the mortality in patients with the congestive heart failure. But the question which is asked is except, that means which is a false statement. If you take the false statement, you take your option B, antagonism of vasoconstriction due to sympathetic overactivity. Remember, the vasoconstrictor activity of the sympathetic nervous system is through alpha 1 receptors, and your beta blockers, they don't have any effect on the alpha 1 receptors, so they don't antagonize the vasoconstrictor effect of the sympathetic overactivity. Definitely, if you take your option C, they will cause the prevention of pathological remodeling of ventricular myocardium, and they are definitely useful in the treatment of a dangerous cardiac arrhythmias. Now let me discuss the last MCQ. Which of these drugs do not decrease the angiotensin II activity? Option A, enalapril. Option B, valsartan. Option C, nesiritide. Option D, omapatrilat. Now angiotensin II activity, it is decreased, or the formation of angiotensin II is decreased whenever you are giving ACE inhibitors. Now these are the list of the ACE inhibitors. These renin-angiotensin aldosterone system activity is also reduced by angiotensin receptor blockers. And now these are the list of the angiotensin receptor blockers. And you take enalapril, it is a ACE inhibitor. You take valsartan, it is a angiotensin receptor blocker. And you take your option D, that is omapatrilat. Omapatrilat, what did we discuss? Omapatrilat will inhibit the activity of angiotensin converting enzyme, and it will also decrease the activity of neutral endopeptidase. So because it is inhibiting the action of angiotensin converting enzyme activity, omapatrilat will also decrease the angiotensin II activity. But if you take option C, that is nesiritide. Nesiritide, it is a BNP analog. This nesiritide, it will increase the natriuresis, but it will not decrease the angiotensin II activity. Now if you take the next MCQ, all of the following drugs are used for the treatment of congestive heart failure except option A, nitroglycerin. Option B, spironolactone. Option C, nesiritide. Option D, trimetazidine. So you take the first option, nitroglycerin. Nitroglycerin, it is a nitrate, And what did I discuss? Nitrates are the drugs which will reduce the preload on the heart. Basically, nitroglycerin, that is nitrates, they are venodilators. That is the reason why they will reduce the preload and they are used in the treatment of the congestive heart failure. You take option B, that is spironolactone. Spironolactone, it is an aldosterone antagonist. So what did we discuss? Aldosterone antagonist, they will improve the mortality in patients with the congestive heart failure. And you take option C, that is nesiritide. Nesiritide, it's a brain natriuretic peptide analog, BNP analog. BNP analogues, what do? They will cause natriuresis. So natriuresis is required in patients with the congestive heart failure. So we even use nesiritide for the treatment of congestive heart failure. But if you take the option D, that is trimetazidine. Trimetazidine, it is a partial fatty acid oxidase inhibitor. And remember, this trimetazidine, it is used in angina pectoris but not in patients with the congestive heart failure. And if you take the next MCQ, drugs that reduce the myocardial remodeling in CHF include all of the following except option A, carvedilol, option B, digoxin, option C, enalapril, option D, spironolactone. So you take carvedilol, it's a beta blocker. It is very much useful for reducing the myocardial remodeling. And you take option C, enalapril. Enalapril is an AC inhibitor. By inhibiting the angiotensin converting enzyme, we are inhibiting the RAAS pathway. By inhibiting the RAAS pathway, the aldosterone is not formed. When aldosterone is not formed, then there will be no cardiac remodeling. If you take option D, that is spironolactone. Spironolactone is an aldosterone antagonist. So if you are antagonizing the aldosterone, there will be no cardiac remodeling. But if you take the option B, that is digoxin, digoxin will only increase the cardiac contractility, but it has no effect on the cardiac remodeling. So digoxin is not useful in reducing the myocardial remodeling in patients with the congestive heart failure. And if you take the next MCQ if you see, which of the following has been shown to prolong the life in patients with chronic congestive heart failure but has a negative inotropic effect on the cardiac contractility? Option A, carvedilol, option B, digoxin, option C, enalapril, option D, furosemide. The question is, the drug should improve or prolong the life of the patient with congestive heart failure, and it should have a negative inotropic effect. Now what are the drugs which will improve or prolong the life in a patient with congestive heart failure? Beta blockers, ACE inhibitors, ARBs and aldosterone antagonists. And among these four drugs, which one of the following has negative inotropic effect? It is the beta blockers which is having the negative inotropic effect. Now among all these four options, you take carvedilol. Carvedilol is a beta blocker. So it will prolong the life of a patient in congestive heart failure and it has a negative inotropic effect on cardiac contractility.